anyway, so it's fairly common. Next slide, please. This is the table of contents for this evening. I will first present a case, and then we will present about the anatomy of the gallbladder, gallstone diseases such as cholecystitis, cholangitis, and others, the differentials, and the management. Okay. So the next slide, please. The case that I have is, next slide, please. Next slide. Ibrahim, can you move to the next slide? Oh, really? Oh, okay. Sorry. Thing is delayed on my part. So I'll just present. Can you go back one slide? Okay. The case I have is a 55-year-old Malay gentleman. We'll call him Mr. R. He has underlying type 2 diabetes, hypertension, and also dyslipidemia. He used to, he's not currently working anymore. He used to work in the oil and gas industry, and he lives in Kuantan with his wife and 5 children. He presented with a 4-day history of right hypochondriac pain. Next slide, please. The pain was sudden in onset, and it started at night, and it was localized to the right hypochondrium and also the epigastric region. He described it as colicky in nature, and it was aggravated by movement, temporarily relieved by painkillers, paracetamol. He took paracetamol. At the he was unable to sleep because of the pain, and he scored the pain 7 out of 10. Other than the other than that, he also experienced fever starting 1 day after he experienced the pain. But there was no chills or rigor. There was no recorded temperature at home, and the fever was temporarily relieved by paracetamol also. Other than that, he had no symptoms suggestive of obstructive jaundice, such as tea-colored urine, pale stools. He also had no nausea or vomiting, and he had no constitutional symptoms such as loss of appetite or loss of weight. There was no symptoms of rectal bleeding or vomiting out blood. Next slide, please. Yeah. Other history is significant for smoking. He used to be a smoker with a 14-pack-year history, but currently he doesn't smoke anymore. He denies any alcohol and high-risk behavior, and a review of other systems were unremarkable. Okay, next, please. On physical exam, the patient was alert. He had a medium bill, and clinically there was no jaundice apparent. Abdominal exam revealed a tender right hypochondriac region with positive Murphy sign and no other significant findings. blood in next slide, please. His blood investigations revealed an elevated white cell count, and his liver function test revealed a mildly elevated serum bilirubin, but it was not elevated enough to cause any jaundice in the patient. Ultrasound of the hepatobiliary system was done and revealed a distended gallbladder with a thickened wall, multiple small calculi within the gallbladder, and there was minimal pericholecystic fluid. Next slide, please. So this patient was diagnosed with acute calculous cholecystitis based on the Tokyo guidelines. Is a definite acute cholecystitis. The patient was managed with analgesia. He was given IV tramadol and also IV antibiotics. He was given IV flagyl and cefovit, and he was planned for laparoscopic cystectomy. That's all. Sorry, there's some technical difficulty with the second part of the presentation. We'll resume shortly.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Can you hear me? Okay, sorry for the interruption. So I would like to proceed with the anatomy and physiology of gallbladder. So okay, so for the anatomy of the gallbladder, So for the anatomy of the gallbladder, okay, so gallbladder is a gastrointestinal organ located within the right hypochondrium. It is a structure. It lies at the surface of the liver, and the capacity of is about 50 milliliter. And its function is to store and secrete bile, concentrate the bile, and secrete mucus. And this physiology of the gallbladder I will explain in the later part. So next is the parts of the gallbladder. Next slide. Next slide. Okay, so gallbladder is divided into three parts, which is the first is the fundus, the rounded and projecting part, the rounded and projecting part of the bladder below the inferior margin of the liver. And the second part is the body. The body is directed upward, backward, and to the left. And lastly is the neck. The neck of the bladder is continuous with the cystic duct. So next. Okay, so next is the biliary tree. So this biliary tree, okay, so bile is secreted from the hepatocyte and driven from both lobes of the liver into the left and right hepatic ducts. This left and right hepatic duct will join together to form common hepatic duct. So this common hepatic duct, the length is 4 cm, and the common hepatic duct will descend and join the cystic duct, which come from the gallbladder and form common bile duct. Cystic duct length is about 3 cm, and the common bile duct length is about 8 cm. The common bile duct has four parts, which is the supraduodenal portion, retroduodenal portion, infraduodenal portion, and also intraduodenal portion. So next slide. Okay, next is the colored triangle, or also called as the hepatobiliary triangle. It is this triangle is bordered by cystic duct, inferiorly, the common hepatic duct medially, and the superior border of the cystic artery. The content of this colored triangle is the right hepatic artery, cystic artery, lymph node of the lung, and also lymphatic. And why this colored triangle is important, because it is commonly referred in the cholecystectomy technique, and usually this triangle is important surgical landmark, because as I mentioned, one of the content is the cystic artery, in which this cystic artery will be identified by surgeon when they perform cholecystectomy to avoid damage to the extrahepatic biliary system. So next is next slide. So next is the physiology of the gallbladder. So bile is produced by the liver and stored in the gallbladder before they are released into the duodenum. So as it leaves the liver, it composed of 97% of water, bile salt, phospholipid, cholesterol, and bilirubin. And liver excrete bile at rate of 40 milliliter per hour. And as I mentioned before, the function of the bile has three functions, which is first, it acts as the reservoir in which the gallbladder will store and secrete bile. And the release of in the duodenum, there are hormone called cholecystokinin, in which this cholecystokinin will trigger the dilatation of the sphincter of Oddi, and this dilatation of the sphincter of Oddi will help to contract the gallbladder. So this will help to inject the bile into the duodenum through the ampulla of Vater. So next, the second function of the gallbladder is to concentrate the bile by active absorption of water, sodium chloride, and also bicarbonate through the mucous membrane of the gallbladder. So when the bile enter the gallbladder, it will become more concentrated, which is 5 to 10 times concentrated. And the third function of the bile is the secretion of mucus. So gallbladder secrete mucus approximately 20 milliliter per day. And if the cystic duct is obstructed, then it will lead to mucocele. due to the result of ongoing mucus secretion by the gallbladder mucosa. So next. Okay, so for the gallstone disease, the epidemiology of the gallstone, it is one of the most common cause of biliary tree disease. It affects 10 to 15% of the population in Western society, and the prevalence is more in female compared to male. So next slide. So these are the risk factor for the gallstone disease. The first is increasing age, and second is the gender, the female, and the prevalence of gallstone is higher in female compared to males in all age group. And also pregnancy is also one of the risk factor for development of cholesterol gallstone. And this is because pregnancy is usually associated with qualitative change in the bile composition and also cause delayed gallbladder emptying, which this both can lead to stone formation. Other than that, the risk factor are diet and also obesity, which also cause the development of cholesterol gallstone. This is due to the enhanced cholesterol synthesis and also secretion. Other than that, medical conditions such as diabetes mellitus and also dyslipidemia also related with the increased risk of cholesterol gallstone. However, how the diabetes mellitus predisposed to gallstone is not well understood, but it may because of the autonomic neuropathy, which can cause gallbladder hypomotility and lead to biliary stasis. And lastly, one of the risk factors is medication such as hormone replacement therapy and also oral contraceptive. But this oral contraceptive has only transient effect in gallstone formation, which study found that when patient start on oral contraceptive, they have slightly higher incidence to get gallstone, but this effect will disappear after 10 years, only transient effect. So next slide. So I will pass my presentation to the next presenter.
Okay, Assalamualaikum. Okay, next is the formation of gallstones. So basically, the major organic solids in the bile is bilirubin, bile salt, phospholipids, and also cholesterol. So usually, any imbalance in the compositions may lead to formation of stones. So gallstones we can classify into two, which is cholesterol stones and also pigmented stone. Basically is classified by its cholesterol contents. Next. Okay, this is an example of cholesterol stones. So back. Okay, so basically cholesterol stone is common in Western populations, and usually the stones consist at least 70% content of cholesterols, and most cholesterol stones are radiolucent. So X-ray is usually not beneficial in investigation, in imaging of gallstones. Next. Next is the pigmented stones. So pigmented stones also contains cholesterol. However, it contains less than 20% cholesterol. So the color, which is dark, is due to the presence of calcium bilirubinate, and we have two, which is brown pigmented stones and also black pigmented stones. So in brown pigmented stones, usually common in the bile duct and rare in gallbladder. However, for black pigmented stones, it is usually found in the gallbladder. Okay, next. Okay, for the clinical features of gallstones, uh, most patients will remain asymptomatic, which about 80% of patients. So the other 20% may presented with biliary colic, which is pain at the right upper quadrant. and also epigastric region. And usually the characteristic is intense, dull, and also persistent pain. Sometimes it can radiate to the back and also right shoulder due to the anatomical site of the gallbladder itself, and may aggravated by consumption of fatty meals. So this is due to the stones obstructing the cystic duct, so that when they eat fatty meal, so the contraction of the gallbladder is insufficient due to the blockage of the gallstones at the cystic duct. So patient may feel pain due to the contraction, and usually it is self-limiting. Next. Okay, move on to the differential diagnosis. So the first is biliary colic. So basically biliary colic is the pain due to the gallstone lodge in the bile duct. So the pain is described as a right upper quadrant pain and presented with nausea and vomiting. For the for the investigation, usually for the imaging, we do ultrasound of the hepatobiliary system. So when we suspect of stones in the gallbladder, we can see posterior acoustic shadowing inside the gallbladder. And for the management, usually we give pain management and also continuous monitoring. However, okay, next slide. Okay, okay. So for this patient, it is diagnosed as acute cholecystitis, which is the inflammation of the gallbladder. So the risk factor includes 4F, which is female, 40, fertile, and also fat. The clinical features includes right upper quadrant pain or epigastric pain, nausea and vomiting, anorexia, and also on the physical examination, we can see positive Murphy sign and also guarding. Patient may present with guarding if the gallbladder is perforated. Next. Next is for the lab investigation. So for lab investigation, due to the inflammation, we can suspect patient may have mild to moderate leukocytosis, and in LFT, elevation of bilirubin and transaminases. And we also need to take serum amylase in order to rule out acute pancreatitis, which also the common etiology is due to gallstones, where it is when the gallstone is stuck at the pancreas. And then renal profile, which we want to rule out any acute kidney injury secondary to dehydration of patients due to patient may presented with a persistent nausea and vomiting. And also for the imaging, same like biliary colic, we do ultrasound of the hepatobiliary systems. And in acute cholecystitis, due to the inflammation of the gallbladder, it can cause prolonged inflammation can cause edema of the gallbladder, and then leakage of the fluid. So this leakage of the fluid we can see in ultrasound, it is as pericholecystic fluid. And also we can see thickened gallbladder wall, which the diameter is more than 4 to 5 millimeter. And in patients with severe presentation, we can do CT abdomen to rule out any complications such as gallbladder empyema and also perforation. Next. So this is Tokyo guideline, which is 2018, which to diagnostic criteria of acute cholecystitis. You can see that the local symptoms and sign, which is presence of Murphy sign, pain and tenderness on the right upper quadrant region, and also presence of fever, leukocytosis, and also in for imaging findings, uh, confirmatory findings on ultrasound, also hepatobiliary scintigraphy. Okay, next. Okay. For the treatment of acute cholecystitis, usually we need to keep patient nail by mouth, which to prevent any further pain due to the contraction of the gallbladder. And then we need to give IV fluid resuscitation due to patient already have if patient have severe vomiting to replenish the fluid and also electrolyte. And of course, patient usually presented with pain, so we need to give analgesia according to the pain score. Next is broad spectrum antibiotics. So IV, we can give IV ceftriaxone and also metronidazole to cover both aerobes and anaerobes. And of course, the definitive treatment is cholecystectomy, which can reduce the recurrence of gallstones up to 80%. However, we usually do not do cholecystectomy upon the patient presentation. It is due to the inflammation is still there, so we need to wait for the inflammation to subsided, and then we can continue to do cholecystectomy. So, uh, there's also indication for emergency cholecystectomy, which when there's a complication of acute cholecystitis, which is there's a perforation or gangrenous of the gallbladder, and also sometimes the disease has progressed to more severe, which is patient may presented with shock. Okay, next. Okay, proceed with next presenter.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So I'm going to present about ascending cholangitis, which it is an obstruction in the common bile duct and causing biliary stasis, bacterial overgrowth, suppression, and biliary sepsis. Okay. So the clinical features is that we are using the Charcot triads, which is right upper quadrant pain, fever, and jaundice, and also a renal pentat, which the patient is having hypotension and altered mental status. Other clinical features is nausea and vomiting, obstructive jaundice symptoms. Okay, on physical examination, we can see in patient having a right upper quadrant tenderness and may have abdominal guarding. Okay, so the etiology is good due to cholelithiasis. Okay, so that there's a stasis of the biliary and biliary stricture neoplasm. Okay, so for example, pancreatic cancer, extrinsic compression, instrumentation of bile duct, and biliary stent. The next. So what we expect in investigation is that we are in blood investigation is we may see leukocytosis, okay, and we need to done blood culture as the most common organism is that E. coli, Klebsiella, Enterobacter. So this was the organism that can cause cholangitis, and of course an increase in CRP. And on liver function test, liver function test, they will may have a raised ALP and bilirubin, and of course we need to do serum amylase. So on imaging, we are having ultrasound of the hepatobiliary system and ARCP. Next, Ibrahim. Okay, so here are the Tokyo guidelines criteria which are used to diagnose acute cholangitis. So we are having here definite and suspected cholangitis. So how we to diagnose the patient is how do we want to use this Tokyo guideline is that we must have any one of the following from part A, which is either fever or laboratory chemistry pattern inflammation such as leukocytosis and CRP. We must have at least one, and then plus with B and C criteria. So B we have bilirubin more than 2, and rest cholestasis parameter and transaminases. And criteria C is that we can see a bile duct dilatation which is more than 7 millimeter and evidence of stones or obstructions. Thus, if the patient having one each one from the three criteria, we can it was a definite diagnosis of ascending cholangitis, whereby sorry for acute cholangitis, whereby if the patient only have two from two criteria, which is the patient having A and have B or C, that's it a suspected acute cholangitis. Okay, next, Ibrahim. So here are the severity assessment criteria for acute cholangitis. We have a grade 1, 2, and 3. So the grade 1 is that the patient does not meet the criteria of grade 2 and 3. So grade 2 we have abnormal white blood cell count, high fever more than 39, older age more than 75, total hyperbilirubinemia more than 5 mg per deciliter. And for grade 3, the patient are having associated symptoms such as onset of dysfunction of any one of the system. For example, cardiovascular dysfunction, neurological, respiratory, renal, hepatic, and hematological dysfunction. Okay, next, Ibrahim. Okay, so the management is that we have one is non-surgical and surgical. For non-surgical, of course, we need to uh, have good hydration for the patient, and of course, pain control for patient, and then antibiotics, and of course, close monitoring for any organ dysfunction or septic shock. Okay. For surgical, we having biliary drainage or remove the obstruction. For example, ERCP, stent, and lastly, we can have the patient can undergo cholecystectomy. The next. Okay, next is obstructive jaundice, which the patient have biliary obstruction of any duct that carries bile from the liver to gallbladder then to the small intestine. Okay, so the patient may present with the right upper quadrant or epigastric pain, nausea and vomiting, and of course obstructive jaundice. Okay, we've seen jaundice in this patient. So so on investigation, we can see from the liver function test the high bilirubin, LP, and direct bilirubin. Because next, we must have serum amylase investigation. And on ultrasound findings of the hepatobiliary system, it may shows there is gallstone and dilated common bile duct. Okay. Next, Ibrahim. Okay. So next is gallstone pancreatitis. As we know that acute pancreatitis, the etiology is that gallstone is one of the causes. Okay, and then where infection of gallstone within the common channel between the common bile duct and pancreatic duct, which there's a intracellular activation of the enzyme, and there's a acinar cell damage, and of course next is pancreatic inflammation. Okay, so investigation that we need to done is that of course serum amylase and lipase, it shows high result, liver function test, and ultrasound of the hepatobiliary system. So how can we manage this is that by ERCP or cholecystectomy. Okay, next. Okay. So here are the previous slide. Okay, so here is the gallstone ileus. Gallstone ileus is due to blockage by a bolus or mass of pass through cholecystoduodenal fistula. Okay, which formation of the fistula from the gallbladder to the what we call duodenum. Okay, so the patients may present with abdominal pain and intestinal obstruction symptoms. Okay, and the patient also may have peritonitis. So investigation that we can done is that plain abdominal X-ray in erect position where we can see there is air in the biliary tract. We call it pneumobilia. Ultrasound of abdomen and CT. So for management for this kind of presentation is that of course laparotomy, enterotomy, and cholecystectomy with correction of fistula with a T-tube drainage. Okay, next, babe. Okay, so here are the examples of the findings that we can see. We have regular site and regular triads. Okay, so regular triads, we can see there's pneumobilia, which is air in the biliary tract, and the small bowel obstruction, and ectopic calcified gallstone. Okay, so the patient may be having the symptoms of intestinal obstruction such as abdominal pain, vomiting, constipation, and so on. Okay, so next. Okay, we pass to the next presentation. Thank you.
So I'll proceed with the management part. So next. So for the first is the investigation. So if the gallstone disease is suspected, so the role of investigation is to exclude any hematological or liver abnormalities and other metabolic disorder, to establish if there is any presence of gallstone in the gallbladder or common bile duct and whether the gallbladder wall is thickened, and assess the integrity and patency of the bile duct system and the pancreatic duct to see any features that suggestive of obstruction. So for the blood investigation, it includes the full blood count and full blood picture to look at the white blood cell count that can shows leukocytosis if there is any infection, and also it is used to rule out any hemolytic disorder because in hemolytic anemia, the hemoglobin is broken down and the heme component is eventually will be degraded into bilirubin and cause increase in the bilirubin, and it can be considered as it can be any predisposed to pigment stone. So next is the liver function test. So in this liver function test, it is indicated to look for any common bile duct stone obstruction. So we can see increase in ALP as well as the bilirubin if there is any biliary obstruction or any obstructive jaundice features. For imaging, include the ultrasonography of hepatobiliary system, ERCP, MRCP, percutaneous transhepatic cholangiography, and intraoperative cholangiography that I'll be explaining more later. So next. So for the first one is the ultrasonography of hepatobiliary system. As what the previous presenter has mentioned just now, the finding will include to identify any stones in the gallbladder, and also to measure if there is any increase in thickness of the gallbladder wall that caused by the inflammation or the fibrosis, and to look for any dilation of the common bile duct system that indicate any distal duct obstruction. So as you can see from the pictures on the right side, there is a layer of gallstone at the aortic region along its posterior wall. So this stone each casts a clear acoustic shadow beyond them. So in an ultrasound, we can see the acoustic shadow that indicates there is presence of stones in the gallbladder. So next. So next is endoscopic retrograde cholangiopancreatography, or known as ERCP. So usually this is used for diagnostic to visualize the biliary tree as well as the pancreatic system. It also play a role for therapeutic intervention, whereby it is used for stent placement for any relief of biliary obstruction due to the gallstone disease. And also it is also used for endoscopic retrograde sphincterotomy, which is if there is any stone found in the common bile duct, used for the procedure to release the stone. The complication in ERCP include the hemorrhage after sphincterotomy, perforation of the duodenum, pancreatitis, as well as any infection that may lead to sepsis. So from next. Okay. So for MRCP, it is a non-invasive technique for evaluating the intrahepatic and also extrahepatic duct, as well as the pancreatic duct. So it is used, the MRCP is used to produce image that outline the morphology of the biliary tract as well as the pancreatic duct. So the disadvantage of using the MRCP is there is no intervention that can be performed, such as stone extraction, stent insertion, or any biopsy, which is ERCP is a more useful investigation. So the advantages include non-invasive, and it can delineate the ductal anatomy proximal to the obstruction. So next. Next is the percutaneous transhepatic cholangiogram and biliary drainage (PTC and PTBD). So this is a rarely used for diagnosis, but it is usually occasionally used for therapeutic indication. So it is used in exceptional circumstances if it is indicated when the endoscopic cholangiography has failed or any ERCP is impossible due to any anatomical constraint from the previous gastric surgery. So for the percutaneous transhepatic cholangiogram, it can demonstrate the bile duct system and to identify any site or causes of the obstruction using a long needle that pass percutaneously and it used into the dilated intrahepatic duct, and the contrast will be injected to display the duct system, and the findings include if there is any obstructive stone, it will produce rounded filling defect, which are suggestive of the obstructive stones. So it also can drain in the intrahepatic ducts when the stricture cannot be assessed at ERCP. So for PTBD, it can locate the site of obstruction and also can insert the temporary catheter to drain the bile, which is the external drainage. So at the picture on the right side, usually this is the configuration for extrahepatic obstruction from the proximal direction. So next is intraoperative cholangiogram. Usually, it is a standard practice to perform the operative cholangiography during the open cholecystectomy. So it is used to identify the bile duct stone that to display the biliary anatomy to show any stones when we inject the contrast will flow freely into the duodenum and also to prevent bile duct injuries. So it is indicative in a patient with jaundice, gallstone pancreatitis, elevated liver enzymes, common bile duct measuring more than 5 to 7 millimeter in diameter, cystic duct more than 3 millimeter in diameter, small gallstone, and also there is visualization of the stones in the common bile duct. So next. So I will pass to the next presenter.
Thank you, Fatin. Assalamualaikum warahmatullahi. So proceed with the treatment. So this is just the general treatment about the gallstone. So we can simply divide it into non-surgical and surgical. So normally non-surgical is not really effective. We use non-surgical treatment for unfit patient to undergo surgery. So one of the options that we can give to the patient is oral drug therapy. For example, quinodeoxycholic acid, which is the bile acid, or other name call it as ursodeoxycholic or ursodiol. So basically, this drug it is slow dissolution of the cholesterol stone, which can improve gallbladder emptying. So when there's improved gallbladder emptying, calcium salt dissolve and stone becomes like a sand. And then a surgical treatment is I've mentioned before about RCP. So I'll talk about cholecystectomy and a little bit about common bile duct exploration. Next. So cholecystectomy is the one of the surgical treatment that we can give to the patient for gallbladder acute cholecystectomy, for example, in this patient. So it is indicated for the patient who has who is symptomatic, or if the patient is asymptomatic gallstone, but they are likely to have future symptoms or complication. For example, patient who have which is high risk patient to have complication, for example, cirrhotic patient, portal hypertension, diabetes. And then the contraindication can be cholecystectomy can be absolute and relative. For example, patient late stage pregnancy normally don't do because the uterine is already big, and then uncorrected major bleeding disorder. But in relative contraindication, for example, obstructive jaundice and previous abdominal surgery because of the adhesion, but we can consider to do cholecystectomy. So first option, there are two. We can do laparoscopic or open. So laparoscopic is gold standard for cholecystectomy. And then it has, you can see it is minimally invasive, and then there are a lot of advantages such as patient able to walk and tolerate after 8 hours post-op, and then 80% can discharge in 24 hours. But some patient, they may need to proceed with open cholecystectomy because of the retained stone in the bile duct, any adhesion, any bile duct injury, and then if there is uncontrolled bleeding. So pre-op assessment, we need to get the consent from the patient for open cholecystectomy, even though we are planning for laparoscopy. Next. Next slide. So this is the overview of the cholecystectomy. So we first of all, we know the get the cystic artery isolated, we clip, ligate, and we divided, and then we follow the. You can read it on later. Next. So common bile duct exploration is another surgical treatment can be performed in elevated enzyme liver enzyme, dilated common bile duct more than 4 millimeter, and then if the patient having history of pancreatitis. So there are two approach, but in essential textbook says oftenly we do choledoscopy. So the first approach is transcystic approach. Next. So transcystic approach is we expose the cystic duct because we know that cystic duct the length is 8 centimeter and the diameter is just less than 6 to 7 millimeter in normal patient. So we expose 2 to 3 centimeter, and then cholangiogram catheter inserted. We inject contrast to look for the anatomy and the location of the biliary tree. And then transcystic approach involve flushing. We give normal saline, we flush, and then small stone can be uh, extracted out, and then fluoroscopy guided basket retrieval is also one of the way to get rid of the stone. Another approach is choledoscopy, which is carried in the essential, where they use flexible fiber optic choledoscope, and then after that, the step is almost the same as transcystic approach, but in this approach, we put latex tube to drain the bile exterior, and then the transverse limb you can see in the picture placed within the common bile duct to provide access to biliary tree for further cholangiogram after 1 week of the operation. So this is just another kind of management of bile stone. We call it as endoscopic sphincterotomy, where we transect the biliary sphincter, which is sphincter of OD, within the ampulla of Vetter. So this sphincterotomy can be done for urgent drainage of bile duct in obstructive jaundice, where it is complicated by cholangitis, for example, and then can be done to retrieve any missed stone after we, after we do the previous operation, and then we remove stone in unfit for surgery. So this is another option for patient who's not unfit for surgery. That's all for today. Any question? So as for summary, mainly diagnose acute cholecystitis by using the Tokyo guideline 2008, and then you follow the management in this patient. Like um, ultimately, we need to do cholecystectomy. But in patient that is not unfit, like I've mentioned about the contraindicated for surgery, then you can give ursodiol, which is bile salt, bile acid. Any question from all of you? Thank you for joining our seminar for tonight. No, doctor. We cannot hear you.
Hello,
Yes, doctor.
can you present the slide, the first slide? So I would like to know what is your main reference? What is your main reference?
Presenter. Hello.
We use generally the essential as well as the Bailey and Love.
Which uh, which Bailey and Love, because I think there is some discrepancy in terms of information. But anyway, so next slide. Next slide. Next slide. Okay, this is one of the case of a typical acute cholecystitis. Okay, basically, I am not very look out into how how does you can, I mean, how does you can get the diagnosis. The more things, the more important thing that I want to look or focus is how you justify on what diagnosis that you be decide. For example, if this you say about the acute cholecystitis, first you can able to mention about other differential pertaining of the clinical presentation that might need that might occur with similar presentation. And then after you consider all the other differential is seems unlikely, you need to justify why you said this is this is typical of presentation of acute cholecystitis. Okay, so I don't want you or any UIA students assume what the presentation of right hypochondriac region. Yes, that might be one of the differential could be acute cholecystitis, but you need to consider or exclude other things first before you said it is acute cholecystitis. Okay, how, although we have all the Tokyo guidelines to determine whether this is acute cholecystitis or not, the knowledge of differential diagnosis is very important, because somehow you will embark with certain presentation that have 50-50. Is it really acute cholecystitis or is it really acute cholangitis or not? And then this is about the biliary system disease. Yesterday we talked that we have one of the patient that we think that is that is almost 90% presentation like a benign presentation of choledochosis. However, when we do the operation, the finding is looks like a cholangiocarcinoma. So that is about the that is about the things about the biliary biliary presentation. It could be anything. Okay, for example, you can look at the patient and the patient have I have been encountered that one of the patient they have a presentation of transaminitis with right hypochondriac pain and no fever, and we do the ultrasound, showed the common bile duct is not dilated. So we just do the endoscopic ultrasound just to confirm that it is not really an obstruction of the biliary stone. So it was surprised that we have a choledocholysis. There is a stone at distal common bile duct. However, the system is not dilated and patient has no presentation of obstructive jaundice symptom. So that is the biliary system. So the take-home message is justification on what things that you want to determine is important. So if you decide this is, I think this is a acute cholecystitis, justify it and prove that other differential diagnosis is unlikely to have in that patient. Okay. Okay, next. So of course, after we see the patient, whether we can treat it or uh, treat it biomedically or surgically. Biomedical, whether we can treat before we can determine the diagnosis, or whether we need to finalize with diagnosis before we can consider a definitive treatment. That for me, that what we call it as a definitive treatment. Definitive treatments needs needs a diagnosis. Okay. Next. Okay, this thing is very basic that you need to know about. Next. Okay, next. Okay, the structure of gallbladder, the component of gallbladder. I think next. The other important things that you need to know about the gallbladder is about the next. Next. Okay, the anatomy is not enough if you want to know about the anatomy of gallbladder. Okay, first you need to know about the structure, and then second, the relation with other organ, as well as the the layers of the gallbladder. Okay, and then after that, all the lymph node and all the blood supply, venous drainage, as well as nerve supply. Okay, then if you know about the position of the gallbladder, fundus, body, neck, cystic duct, how does it look like? What is the relation of common bile duct between the common bile duct, hepatic artery, and also the portal vein? Then you need to know about the variants. But that one is, I think, is not under undergrad level. Just enough that you know about the relation with other organ or other structure surrounding the gallbladder. Okay. Then after that, about the physiology system and how does this how does this physiology can be interrupted because of anything, because of high concentration of cholesterol and all. Okay, next. So another thing that's also important is about the physiology of certain things. For example, like how does the pain can be developed in patient with cholelithiasis. How does the formation of the gallstone can happen in the patient after the stone impeded in the cystic duct? What is happened towards the gallbladder, and what is the complication after that, and until the final completion? What is the worst thing that can be happen? Another thing about the pathophysiology is about in patient with acalculous cholecystitis, what is the pathophysiology behind that? So that's also is important. Okay, I hope you can jot down, find the answer, and understand it. Okay. Next. Next. Okay, next. All right, next. Next. So what is the definition of biliary actually? So you need to understand about that. So first is about the definition. Second is about the characteristic and how does the biliary different with other type of pain towards the gallbladder. I mean type of pain over the right hypochondrial region. Next. Next. Okay. So you need to know what is the pathophysiology of biliary leak. Okay, it's not because the gallstone lodged in the bile duct. So this statement need to be corrected. Okay. So you need to know about the causes or pathophysiology behind it. How does the biliary leak develop in patient with cholelithiasis? Next. So due to blockage, okay. So this also need to be more detail on the pathophysiology of acute cholecystitis. How does the inflammation can develop after the gallstone block? Okay, so after the gallstone block, okay, in this diagram or this illustration, notes that there is presence of, they said there is a presence of bile buildup. So can you imagine on how does the bile can be built up after the stone has been blocked at the cystic duct? Because we because you know the formation of the bile is coming from the liver. So it's actually the bile. I mean the gallstone. I mean the gallbladder become inflamed because after the gallstone block the cystic duct, there is an expansion of the fluid accumulation that mix with bile, and this can cause edematous surrounding the gallbladder. And then after that, there is a blood or vascular compromise, and after that, there is presence of micro ischemia. Okay, followed so, along with the inflammation. So that's why there is the pathophysiology of acute cholecystitis can be formed. Next. Okay, next. Okay, for all of you, I don't emphasize all of you to know about all the Tokyo guideline 2018 and all the fancy name of the guideline. It is enough for you to know about the principle on how to diagnose certain things based on, not just rely on diagnostic criteria, but based on the clinical presentation of the patient itself. So
So justification is important, as I mentioned for you before. Whenever you determine your or finalize your provisional diagnosis, you need to justify this, and that based on the history and or the clinical presentation or findings that you have got. Next. Okay, same like the investigation. Okay, investigation. For example, like patient came to you with right hypochondrial region pain, then you have listed all the differential diagnosis in your mind. Then after that, you confirm it with detailed history from the patient, and after that, you do the physical examination. Then you finalize your diagnosis and consider other differential diagnosis that can be considered with similar presentation. So for the investigation, first you will mention about the biochemical markers or biochemical laboratory investigation, like full blood count. You need to mention why does you want this, why does you want that. Basically the full blood count, renal profile, and liver function test is generally we use that to get as a baseline first, or we want to determine whether this patient have got some baseline, and this patient have got some infection or not based on the inflammatory marker of total white count or ESR or CRP. The liver function test can be determined whether this patient have sort of liver injury or have some presence of transaminitis due to obstructive jaundice. Okay, then you will go to imaging. So basically, you can mention about the ultrasound hepatobiliary system because you want to determine the diagnosis. But don't forget to mention about the chest X-ray as well. Okay, because we need chest X-ray because you also want to exclude other differential diagnosis like pneumonia. Okay, then how about the abdominal ultrasound, abdominal X-ray? We usually don't do the abdominal X-ray if we don't think that the intestinal obstruction is not listed in your differential diagnosis. So no need to mention that. Why does you see all the patient in the ward have got the abdominal X-ray? Usually it is because we are not the one that ordered the abdominal X-ray. We only order the abdominal X-ray if we think that intestinal obstruction is one of our differential diagnosis. Okay, understand? Okay, I hope you understand about that. Next. Okay, this one is also important. Charcot's triad, Reynolds pattern. Classically, we use these to diagnose ascending cholangitis. Okay, next. Next. Same like what I've mentioned before, this is good to know. I not emphasize you to mention about the Tokyo guideline because at your level, the the fancy names of the all the guidelines is not really um, uh, suitable, or is not really important for you to know about that. You need to know the basic principle first, then you can use to apply all the guidelines later. Okay, next. Okay, basically we will, according to acute cholestatis, cholangitis, we grade it by the Tokyo guideline. Will grade it as a first diagnostic criteria, and then second about the severity or grading system. So this grading system will determine the management on patient later. So the issue is that with regards to acute cholecystitis, they have an argument on when does the patient need to undergo acute laparoscopic cholecystectomy. Some said less than 72 hours of onset, we can still perform the acute cholecystitis. It's still safe and effective, and it have a better, similar outcome, but better better benefit, good benefit compared to delayed onset of doing the laparoscopic cholecystectomy. However, for you to uh, know about that, it is not the suitable time yet for you to know a detail about that. Just know that the definitive treatment for acute cholecystitis is laparoscopic cholecystectomy. Whether it is an early or delayed, it depends on the situation of the patient and severity. Another option that can we do for the acute cholecystitis when the patient is not unfit and in very severe, that we suspect that patient have sort of perforation or gallbladder empyema, that we cannot do the operation. The treatment is called as percutaneous cholecystectomy. Percutaneous cholecystectomy is different from percutaneous transhepatic drainage, and it is for decompressing the biliary system from the intrahepatic duct. While in gallbladder empyema, we want to drain all the pus and all the content in the gallbladder from the fundus via percutaneous cholecystotomy. So the definition you need to know is important for you to know. Okay, next. So in conclusion, okay, there are a few kind of complication that can be developed pertaining gallstone disease. Okay, so I think for you to know all complication that can happen in um, the gallstone disease, as a surgeon, I prefer you to read from the source. Although the source, it can be very detailed, as for you can have a look at the outline of the, the chapter of the gallstone disease, and then you can read further after that. So they have enlisted all the relevant surgical complication pertaining gallstone disease, and all the principles of treatment. I think that is one of the best book that I think you need to look for. Okay, because like what I said, the treatment and management can be arguable because we want to see the outcomes. So the issue is about what is the best treatment and what is the evidence to support all the treatments that that we offer. So basically, the treatment still the best treatment for the gallstone disease is still remove all the gallstone and the gallbladder. And if it is obstruct in the common bile duct, we need to remove the stone in the bile duct. Usually after if the patient has some problem with the sphincter or sphincter of Oddi. So if after we do the sphincterotomy, then the bile will be flow nicely. After that, usually the recurrence rate can be reduced, but there is still about 2 to 5% patient can develop hepatolithiasis, which is the formation of stone within the intrahepatic duct. This also can occur in a few population of patients. So that is benign disease. Although the inflammation of the gallbladder is, and also the cholelithiasis and common bile duct stone is benign disease, but it can carry severe complication from the disease itself, and also it also uh, can have a complication due to operation itself. Okay, sometimes the operation can be for the patient with simple, acute, not acute, for the patient that have biliary colic alone. So we do the operation. Usually, the condition of the patient will be quite nice. Okay, without any adhesion. Okay. However, Ibrahim, that he assist me just now, patient that have history of gallstone pancreatitis, for example, or history of cholelithiasis. Okay, we expect that patient will have inflammation, and then the post-inflammation, as you all know, generally will develop adhesion or fibrosis. So the condition of the patient during the operation will be more complex. But now, as but as an undergrad student, that issues is not your issues as for now, unless you will become a surgeon. So that is the things that we need to emphasize or focusing more. Although it's a benign disease, but it also can be disaster if we treated it wrongly, or treated it with with careless. Okay, with careless. So that is about the gallstone disease. After apart from the surgical treatment, still until now there is a few things that people are suggesting to treat the gallstone disease. For example, like all the medication, like what your colleague said about the urso or apa, oxycholic acid. That one is still not efficient. If it is available, it is only for patients that have not to have any gallstone, we want to prevent it to occur, then that one can be prescribed or could be efficient. But still, patient with gallstone disease, okay, other modalities like, for example, like in the renal stone, you can give extracorporeal shockwave, but it's not applicable for gallstone disease. Okay, only cholecystectomy, which is efficient, 100% free recurrence rate, almost 100 lah, almost hundreds. But sometimes patient can be recurred for due to retained stones or hepatolithiasis, but still surgery is still a treatment until now. Until now, surgical treatment is the only treatment to treat complex or complicated gallstone disease. Okay. The difference is about the type of investigation, and also other surgical treatment for the initial management, but surgical treatment is still and also if there is a stone in the bile duct, we can do ERCP. Okay, so another thing that I want to emphasize is about how you mention about the investigation. Okay, some colleagues, some of your colleagues mentioned that MRCP is better than ERCP, but we cannot do MRCP because it's not offered the therapeutic strategies. Usually, when I discuss with interventional or radiologists, they said, although actually to delineate the biliary system, MRCP is actually not really clear compared to the ERCP or endoscopic ultrasound. However, the good things about the MRCP, because we can delineate the whole biliary system, including pancreatic ductal system. So that's why MRCP is better. But in terms of clarity of the imaging, still endoscopic ultrasound and ERCP is better than MRCP. Okay. Okay, I think is there any question from all of you? Okay, so I encourage you to read about the disease further in source textbooks, okay? And then I think if you got time lah, because I've been informed that about a few weeks from now you will have your end of block exam, but it's okay. This is not you cannot think the knowledge is just for your exam only. You need to improve your knowledge further if you want to become a better doctors. So if you if you have any question after this, you can private message me or email me, and I will answer if I can answer it. Okay. If there is no question, I think we can end up the session here. Thank you.
Thank you, Mr.
Thank you, Mr.